Hi there. Thank you, Mohini. Good evening, everyone. We're just going to present some of the changes that are in the latest version 3, which was released on the 16th of April. This, as you can imagine, COVID, our experience is rapidly moving and things change very, very quickly, and we need to keep this updated on a regular basis. So even by the time that I go through the changes that we're talking about, we're already writing version 4. Hopefully next week, we'll be able to present you even more changes and keeping you as up to date as possible. But I'll highlight some of the possible changes that are going to come up in version 4 as well. We're not going to go through all the things that we talked about last time, but some of the things that I'll just highlight some of the major changes. One of the things that, so going through the first part, the zoning has not changed, as you can imagine. So everybody is now doing hot and cold sites or having a mixed model with hot and cold zones within each particular practice. One of the things that people were talking about a lot was how we identified patients with hypoxia during the second or third week of their COVID illness. And we have seen people who have continued ill into their second week. And people were reporting that patients were not necessarily very breathless, but profoundly hypoxic. And this is a common occurrence now that we notice it. So we have added a paragraph in the section about assessing a patient remotely, which is talking about comfortable hypoxia. There is no way, I'm afraid, of actually accurately detecting hypoxia in patients other than by doing pulse oximetry. Unless you can remember how to look for cyanosis. I know that is something that we've all forgotten nowadays because we now have pulse oximeters. So if you are doing a video consultation and the patient's obviously blue, then that might be a good sign. But otherwise, trying to get a pulse oximeter to them some way is the only reliable way of actually detecting hypoxia. So some CCGs have had innovative ideas about getting pulse oximeters to patients either by using a courier service or getting medical students to cycle pulse oximeters to patients. Or sorry, can people put their microphones on mute, please, whilst we're talking? And the other way is to get the patients up to your hot site or hot zone in order to do the pulse oximetry. I'm afraid that is the only reliable way to actually detect hypoxia in our patients. So we have this paragraph there just to highlight patients that may have this comfortable hypoxia. The pathway diagrams have not changed, but they will be changing for version 4. So this is just a warning that this area here, we've had some concern from our care of the elderly colleagues and from the Frailty Network. We might be excluding completely patients from admission who have frailty, and this is certainly not the case. So that there'll be some slight modifications saying that perhaps that patients that are frail and are hypoxic, that sometimes hospital admission is the only suitable place for them. Again, in the second pathway diagram, nothing much has changed on this occasion, but there will be changes in version 4. Again, we're beginning to recognize that some of the things that we need to identify sometimes is that patients may be, if you're seeing them in a hub or seeing them at home with a pulse oximeter, that patients may have reasonable pulse oximetry at rest, but sometimes these patients can be, can desaturate when they're actually moving about or exerting themselves. So in the next version, we'll be talking about how to actually detect desaturation and what the best way of actually detecting desaturation is, and what sort of level that we would be recommending referral into hospital is. But at the moment, this is how it stands. But in the next iteration, there may be some slight modifications. There is a slight error here that may be causing some confusion, which was highlighted to us today, is that in the medium risk and in the high risk categories, there is an overlap of 94%. This is caused by, unfortunately, us trying to align with the NHS England and NHS Improvement Emergency Department guidelines, which use a cutoff of 94% or more, which then means that there's very little leeway for low risk and medium risk groups. We in the network feel that 94% or more is probably a bit more generous than we would expect, and certainly more generous than the version 2 that we were using. And I think that we have to use our clinical acumen in assessing patients with 94%, that perhaps they don't all necessarily need to go into hospital, especially if they have adequate safety netting. One thing that I should highlight as well is that previously we have recommended the prevention of secondary bacterial pneumonia, and that we give guidelines as to what antibiotics to choose in the appendix. But in the future, it may be that we are not going to recommend the prevention of secondary bacterial pneumonia and only treat when there is a high suspicion of bacterial pneumonia. And that will be in concordance with the NICE guidance on the treatment of pneumonia in the community. The treatment of asthma and COPD hasn't changed. Here, some additions that we have is about safety netting. We are discharging more and more patients now from hospitals, and we are looking after more patients in the community who have COVID. So we are giving, in the box 2 there, we are giving some guidance on safety netting. In low-risk patients, the ones that were in the previous diagram here, low risk, they will just perhaps get away with just general advice and to call 111 if they continue to deteriorate. For the medium risk patients, we would recommend that they are reviewed on a daily basis with a phone call or a video call to assess their level of breathlessness, and some way of doing pulse oximetry on them for a couple of days until they are stable or improving in a trajectory that is continuing to go up with their pulse oximetry before further discharge and becoming low risk. So this is just a little bit of guidance about how you might want to safety net. The management of home visits has not changed. PPE is much the same. One of the big issues that we have noticed is that I know that some of you will have received guidance from your LMC, I think it was, about cardiopulmonary resuscitation. You may all be aware that there is a big debate at the moment, sort of a disagreement between Public Health England and the Resuscitation Council UK about what constitutes an aerosol generating procedure. The PHE maintained that chest compressions are not a aerosol generating procedure, whereas Resuscitation Council UK and the World Health Organization say that it is potentially a AGP. There isn't any necessarily good evidence for it, but they are extrapolating from other data, and they consider that that's good enough to recommend that if you are going to do chest compressions, that you should only do that with full level 3 PPE. So that means a FFP3 mask and eye protection and a full gown as well. But obviously in primary care, that's not going to be available to you. So we are saying that currently that if you are a first responder or in a primary care setting, that you do a risk assessment on the situation. And this is a matter of personal choice whether or not you proceed to doing chest compressions or not. Generally speaking, if you are dealing with a COVID patient, you will be wearing a face mask and gown, an apron and gloves anyway. So you are in a way protected, and further protection can be gained if you are going to do chest compressions by putting a cloth over the patient's mouth and nose whilst you're doing the compressions. And indeed, that is the advice given by the Resuscitation Council UK on their website. If you are a first responder in a community setting, not in a hospital setting, but in a community setting, they do say that you can do chest compressions without PPE, but placing some sort of covering over the mouth and nose of the patient. So we might be getting further developments on this in the next day or two, and we might see PHE and Resuscitation Council come to some sort of agreement, and we will certainly update version 4 if there is something that they agree on. So treatments considered, again, we just highlight the fact that we recommend everybody who has long-term conditions to be considered for a CMC record and to also determine their advanced care plans. The treatments to be considered at home haven't changed very much, although, as we said in section 252, where we're talking about antibiotics for the prevention of secondary bacterial pneumonia, in accordance with NICE in version 4, that will probably change to say that you should only give antibiotics if you actually suspect that there is a bacterial pneumonia. And we'll be describing how you might be able to differentiate between what is a bacterial pneumonia and what is COVID, cough and fever at that time. Post-discharge arrangements. So again, this is talking about the use of safety netting and oxygen therapy in patients post-discharge. So a lot of you will now be looking after patients who have been on the wards with more serious disease, and even some that have come off ITU who have been on ventilation. Because there hasn't been such a push on beds, patients have been allowed to stay for a bit longer than we had anticipated, so that patients now are unlikely to be discharged from the wards whilst they are still hypoxic. So the need for oxygen is actually probably only theoretical rather than a practical consideration. We give a pathway as to how patients should be safety netted following discharge from either the emergency department or from the wards. And we give an algorithm with some risk factors, and that if patients do have 2 or more risk factors, either when they're discharged from the wards or from the ED, then we will recommend that they are followed up on a daily basis with pulse oximetry if it's available until they are deemed to be stable. And we give reasonable discharge criteria there as well from continued follow-up. So hopefully this will give you some reassurance and some guidance as to how patients can be safely monitored following discharge from hospital. I'm pleased to say, though, however, that our experience has been that many patients that have been discharged have continue to do well, and there are not many instances of failed discharges apart from for social reasons. Some further guidance on who are the vulnerable patients that you may want to be careful about who are discharging. Discharge to nursing homes. Again, there is a lot of debate currently about how safe it is to discharge to nursing homes a COVID patient. The guidance from PHE has been slightly confusing, and we'll be providing some further guidance in version 4, but unfortunately I'm not sure that PHE has been of that help. It says that patients who are being discharged from hospital should have should be tested for COVID to see whether or not they are still positive in terms of whether they can still detect RNA prior to discharge. However, The guidance also says that there is no need to wait for a result prior to discharge, which then sort of begs the question of what's the point of testing if you don't have to wait for a result? Because they are saying that the whole purpose of testing them is to see whether or not they need isolation. So one would presume that when you discharge a patient back to the nursing home, they should be isolated pending the PCR test following their discharge. So it's slightly confused, and hopefully we'll get some more clear guidance about discharging back to care homes and nursing homes. And obviously there is a lot of anxiety amongst the public at the moment about patients who are being cared for in these institutions. The advice on oxygen therapy hasn't changed very much. We're saying that most patients who are being discharged should not be hypoxic. Patients who are hypoxic and choose not to go into hospital, if they're on a palliative care pathway, they may not need oxygen because most patients, as we said, can be very hypoxic but not breathless. So therefore, they do not necessarily need oxygenation. But if you think that their trajectory, that they are not necessarily going to die, they're not in a palliative pathway, and patients have chosen to stay at home, to be managed at home rather than in hospital, then we do give some guidance as to how oxygen can be obtained or can be tried in order to maintain them at home rather than sending them into hospital. The palliative care section has not changed. The business as usual section has not changed, although it will be changing in section 4, in version 4, because we will be, the section that will be changing is about inhaled steroids, because patients that are on, what has changed, the section that we used to talk about the reduction of inhaled steroids in patients because of the risk of pneumonia with high-dose inhaled steroids, we have now taken away because NICE guidance has said that during the COVID pandemic, that we should not be trying to reduce or stop inhaled steroids in these patients, even when it's high dose, for the risk of destabilizing the patient. So that element has changed. So what we have got instead there is to tell patients who are established on inhaled steroids to continue their use and to delay any planned trials of withdrawal or reduction till after the pandemic. The only other changes we have added in the appendices something that's quite useful for those of you who are working in hot sites, and that is the use of oxygen in a hot site. We know that there has been some delays in perhaps in LAS getting to hot sites to convey patients to hospital, and people have been asking about how they would use oxygen, and we have given some guidance as to what the equipment that you might need, what types of masks or nasal cannulae you can use, and there is an algorithm as to how you progress oxygen treatment according to oxygen saturations, and what are the target oxygen saturations that you can aim for whilst you are waiting for the ambulance to arrive. So hopefully this will give you some reassurance about managing patients who are profoundly hypoxic that you may come across in your practices. Nothing there has changed. That's all still the same. In the next iteration, we're going to have a slight more expanded version about using the clinical frailty scale. So that's coming up. The appendix on pre-existing lung conditions, that stays the same. And we have a big section on how to use Coordinate My Care, because we feel that's really important. And then finally, there is this section on managing breathlessness at home in patients who have chosen to stay at home. So this bit is quite useful for those patients who are choosing to stay at home, and how we can manage breathlessness without the use of oxygen, and how we can do it with without the use of drugs as well. So those are the main changes that we have had in version 3. And as I said, hopefully they should make more sense to you and give you a bit more guidance about what is happening in the community right now.
Thanks very much. Thanks, Vince. The guidance is fairly clear in that the care homes are not accepting patients from discharge, and we have actually built in Northwest London a transitional arrangement. So if patients have got a positive result, then they will go to this transitional arrangement for 14 days. And even if they've got a negative result, some care homes are not accepting patients, and we have built-in capacity for transitional support post-discharge. So this is in hand, and it's being managed by the quality team and the continuing healthcare team across Northwest London, across all the boroughs. Sarah, did you want to come in now to pick up the questions? There were a few questions that I had picked up, or have you got most of them?
Yeah, I think so. Hi, everyone. Nice to see you all, or not. It's a beautiful evening. So what I was going to do is go through the questions we'll be getting on the support line, because they may answer a lot of questions. And also you can see how the questions that are asked to us on the support line feed into the iteration of the guide that we give. So it's really important. And I have to say that the questions we get asked are really sensible. Sometimes we can't answer them. Sometimes we're very honest and say, look, we'll take this back and get a view from more of the experts. So bear with us on that. And as Vince said, the guideline is changing really rapidly because we have learned a lot about this disease in the last 6 weeks. So next slide, please. So these are days 5 to 15 of the support line. We went through the first 4 days on the last webinar. So the queries really are mainly what Dr. Mack has been through. We're getting asked a lot about oxygen saturation and how to use it, which is very sensible. We've been asked about asthma bronchiectasis, about what to do with borderline oxygen saturations, and also what to do about post-exertional saturations that drop. I was asked about what a significant drop is, and we normally say a very significant drop would be 4%, but you'd worry really at 2 to 3% in a drop in a person that does not have lung disease. We shouldn't do that. Also asked about the risks and whether we'd look at different saturation drops in different conditions. The only thing that we would look at differently would be COPD. Next slide, please. So the key messages from SATs are we should assess SATs at rest and following a walk test. Currently it describes breathlessness on exertion, or if you have concerns as a clinician. If the oxygen saturations are 94 to 95 at rest and following exertion, i.e. it's not desaturation, consider monitoring these patients at home with oximetry daily or BD if they have concerns or you have concerns. The thing to say here is when these patients in a 94 to 95 bracket become unwell, they become unwell fast. So you really do need to phone them twice a day to make sure they're fine. If their SATs are picking up, that's also a very positive sign. Always ask about exertional symptoms. Many patients will say to you, I feel absolutely fine, I'm not breathless. But when you push them and you say, how are you getting up the stairs? Or how are you when you're walking around? They will say, it's a little bit more effort, or I feel very tired when I'm doing this. If significant desaturation at rest, then consider hospital assessment. I think that's absolutely fine. And as Vince says, the guide's been changed now, which is less than or equal to 94% and significant desaturation on exertion or an increased pulse and fever. It's better that we assess these patients and decide if they need to stay in for oxygen and observation, as if they do go off, then there is an opportunity to ventilate or give other interventions. There's also a lot more trials going on in hospitals now that we wish to enter patients into to see if they are of use in case we have another surge. So for COPD, we've put some guide it's in the guide, but really to say mild deterioration 2% below, moderate 3 to 4, and severe 5. I'd say 4 to 5 is quite severe. But also if they're on oxygen, if they've gone below 88% on their normal oxygen prescription, then that would be a concern. Next slide. We've been asked about tachypnea. A lot of people say, my patient's breathing fast. I'm not really sure whether it's linked to COVID or not. They've had a COVID-like illness. Again, the advice is the same. Check the observations at rest and post-exertion. Are they getting more breathless when you're watching them if you're doing video conferencing? And remember, there's various causes for isolated tachypnea, the same as always with infection, VTE, and also anxiety. We've had several calls this week where I think general practitioners know their patient is anxious, but just want reassurance that they're not missing anything else with COVID. And there's been lots of news stories about VTE and thromboembolism, and lots of concerns about, could this be a P that we're missing? Again, I think the SATs are, if the patient has no exertional drop in SATs, it's less likely. But if you have concerns and this patient has other risks for VTE, then always think about getting them assessed. Next slide. Yes, tachycardia. So again, the next thing I've been phoned this week with tachycardia and bradycardia, actually, interestingly. Really, again, very typical COVID symptoms, getting better, feeling well, but remaining tachycardic. It's just to remember, it may be driven by ongoing infection. It depends on the stage and how late after the initial symptoms were, and also dehydration. It's also, however, be mindful of arrhythmias, and we've seen a few people with atrial fibrillation coming into the ED. As regards persisting significant tachycardia, no other cause, and treat them exactly how you normally would, and always think, what would I normally do in these situations? Yes, it may be COVID, but what would I normally do, and do that. We are beginning to see our ED filling up with, as we say, normal medical things, but there was a real lull for a while, and I think people were very scared of coming forward to casualty. Bradycardia, we haven't really seen this occur, and I think if someone is bradycardic, they should have an ECG and to check why that may be. Next slide. I can see a question. Yeah. If they come to casualty, we do a D-dimer. We do D-dimers. We do we do a chest X-ray, and we do BMPs. We've got a whole COVID screen that we do. Use and choice of antibiotics, we've been asked about this. Vince has covered this a little bit, just to say that it's reasonable to give antibiotics now if there are concerns regarding secondary bacteria. So how long after the initial symptoms are these, and also are they coughing up green phlegm? So clinical acumen really, and doxycycline still remains first choice of those. We've been asked, shall I give dual antibiotics? No, don't routinely use dual antibiotics. And if no improvement in the early phases, then this is most likely a viral infection. Standard course of 5 to 7 suffices, and useful to send sputum MCNS if there are concerns remaining, lots of phlegm, or they have bronchiectasis. And remember, with bronchiectasis, we had a few queries this week. Respiratory advice is 10 to 14 days of antibiotics for someone with known bronchiectasis, not 5 to 7, so that's slightly different. Next slide. So this is really interesting. We're seeing more and more patients that are having longer and longer symptoms, and that they're having persistent symptoms for several weeks. And actually, some of them are getting improvement, then coming back again with coughs, etc., persistent fevers, not every day, but maybe every other day. And so I've done some reading, and actually, when you look at the literature, the average length of symptoms is 14 days. So actually, you're going to get some people that actually have longer length of time with symptoms. It doesn't necessarily correlate with severity. It just means their symptoms may go on for a bit longer than those normal 14 days. The fit and well can get better within a week at most, but it's definitely a theme that I'm hearing from primary care, that you are seeing these patients that have persistent coughs, persistent fevers. So when should you worry? I think if they're stable, if they're not having really high fevers, and if they feel their general trajectory is getting better, then sit tight, keep them under your radar, but don't worry too much. However, if the fever could be linked to something else and you're not, you thought this was COVID, again, go through your sieve. Could this be anything else? Just to say, we've had a real reduction in TB referrals. Something's happening out there. We don't know why. They've suddenly gone down. So do suspect this in individuals too. Think, could this be something else? They've got fevers. Have they got night sweats? Have they got any other symptoms that may be another kind of pneumonia or diagnosis? asked whether chest X-ray is useful. If they're breathless, continues at rest or exertion, probably. I think if they've not been seen in hospital and never had an X-ray, then yes, they should have a chest X-ray. We are beginning to want to follow up chest X-rays now. We don't know the long-term sequelae of this disease, and we need to be absolutely sure we have information about this. Next slide. So management discharge from hospital, interesting. So again, we know that LCW will be following them for the week. Afterwards, we're beginning to get more concerned about patients coming out of hospital, and we will, as Trust, begin to safety net our patients very soon. Also, the ones that you guys may send in. If we then send home again, I think it's our duty of care to make sure they are stable and watched. So what sort of symptoms are we getting asked about on the support line? We're getting asked about pleuritic chest pain, breathlessness, hypoxia, ongoing dizziness, and persisting fever. The key messages are really if they're hypotensive, then they need to come back in and get urgent medical assessments. Again, as I said, symptoms can occur and keep going for a few weeks after first diagnosis, and if the general trajectory is getting better, then hold fast. Again, COVID patients are considered to be at higher risk of PE. To put it here, the data is still being collated, so it's important to know about this. And we are muting that high-risk patients that we're sending home. We may give 2 weeks of NOAC moving forward, so you may see that, but we're discussing it amongst the clinicians in the trusts. As I said before, difficult to exclude PE on history alone, and desaturation and exertion may help you. It's unusual when they get home from hospital, but we are seeing a few that are coming back in with PE, but they're very symptomatic, actually, these people that come back in and on exertion, not at rest. So always ask them about that. Next slide. This was an interesting one. So we got asked by a general practitioner, I think in H&F, about a rash, and when we looked it up, there are some dermatology sequelae, just like any other virus. So again, look at the rash in the same way as you would any other viral sequelae. If it's blanching non-petechial rash in mild COVID, it's probably linked to the virus. But if it's anything else, then treat it as if it's any other rash. Next slide. Steroids, this is just to go through again. We mentioned it last week, but basically with asthma and COPD, if they have a fever and could be COVID, then we say no prednisolone, so 37.8. If they're typical symptoms of their asthma or COPD, then yes, they can have prednisolone for 5 days or 7 days of asthma. So do use again your clinical acumen. I don't know how to turn off my beep sound, actually, sorry. Inhalers. So again, I think all the asthmatics in the whole of the UK are using all their inhalers all the time, because we know that the stock has gone down. Important to advise all asthma and COPD to continue on their regular inhalers, but not to stockpile. And we're saying just give your prescriptions in a normal way, on a monthly way. There's still no spirometry or lung function data available, but if you suspect a diagnosis of COPD or asthma, a trial of treatment seems reasonable at this time. If you're using peak flow monitors, they need their own peak flow. It's not such a problem for you, but in clinics, we have to give individual now if we're going to see them. We're not yet sure when spirometry or lung function will reopen. Again, it won't be while lockdown is occurring, but we'll need to think about the way that we set that up, and we'll advise you further about that. Next slide.
Oh, I'm glad you're bringing this up. I was going to ask a question.
Yeah, that's an interesting one, isn't it? I'll just turn off if I turn off my chat, you might get rid of my noise. So let me see. Hopefully. Right, chest pain in COVID. Could this be myocarditis? Now, it's really interesting, and I think there's been lots of webinars about it from Italy. When you really look at the myocarditis question, it seems to occur in about 2 to 3 days after a high fever. So they've got a high fever, 2 to 3 days of symptoms, and they will get myocarditis at that point. So severe onset of virus is associated with hypotension and plausible clinical presentation. So acute chest pain, acute or chronic heart failure, or an arrhythmia. So again, if they've got tachycardia and they're specifically unwell, then think about it then. But generally, it's associated with early severe disease in the studies that we've read. Important to consider the symptoms in the context of the rest of the history. So if they've got any of the above, they do need a hospital assessment or an ECG, and we normally do a troponin and a BMP in those patients as they're markedly raised normally. We really haven't seen it that much. I went through with my colleagues before tonight, and so from the admissions, is it because we're not seeing it because we're so much looking at their respiratory symptoms and their oxygenation? Who knows? We do know that some people have worsening heart failure, but they're normally patients that have an underlying ischemic heart disease pattern already. Yeah, so there's a very good palliative system within the document. However, the most important message is that with palliative care across North West London's really thought that they want to keep their palliative care pathways local. And I think that's fair enough, actually. They want their relationships to stay, and for any queries about that to be set up with your local hospital services. Oxygen is often brought up. The bottom line is if this patient really is dying, it's unlikely to help. And actually we've found that drugs such as midazolam and opiates appear to relieve their symptoms much more. If agitated, we've found that antipsychotics can be very helpful in the hospital setting. And we are seeing people that get almost out of proportion agitation. So their oxygenation's okay, but they'll be really agitated. And we wonder whether there may be some effect on the brain by this virus. And there's a little bit of research going on with that. If very breathless and hypoxic, a trial of oxygen can be considered and continued. So this is really from the palliative care oxygen guide. But if it's not helping them, then we wouldn't carry on. And just to remember that oxygen is for hypoxia and not for breathlessness. So if someone's not hypoxic, it's not going to help them. And don't use fans with COVID patients as it will disperse virus. Next slide. This was a sad one in that someone phoned up just wanting to know they had an elderly patient with COVID symptoms, they were unstable, and they were worried that the patient would get turned away from hospital. These patients will not get turned away from hospital. It's just not true. Age is not a reason not to refer someone to hospital. And it'll certainly not be a reason why we would not admit them. We've got patients of all ages in the hospital, and actually some of the very old have got better and recovered from COVID. So they've been supported by oxygen. Yes, it's a poor risk factor, but it doesn't mean to say they shouldn't get oxygen and get care within the hospital. So don't, the real issue is, does the patient want to come to hospital? What's their advanced care plan? Do they have a lot of comorbidities and frailty score? So if their frailty score is very high, then it might not be the right place for them. But if they generally have a good performance status before they come in, then they may well come out again. So if a sensible decision is made, so if it's a sensible decision with the patient to stay at home, then support services should be available, i.e. palliative care, to support you and the patient and the family there. Next slide. So there you are. That's done. So
thanks, Sarah. That was really helpful. Well, there were just a couple of questions, if I could that I've tabulated. One was around, could you just spend a moment talking about Medopad and how we are going to be rolling out oximetries? I know it's not going to happen in Ealing, it'll be central and Hillingdon to start off with, and then around that. And then there was a question for me about, if you could just spend a moment about the sequelae of COVID in terms of, do they need monitoring for UNEs? Because there's evidence that, people have run into renal problems. So week 2, week 3, is there anything for follow-up there? And somebody with COVID who's 3-4 weeks, where do we start thinking about PEs happening? How long after COVID can people still present with PEs if there's no breathlessness, cough, or is that just post-COVID cough?
Okay, so should we start with Medopar, and Vince maybe? Yeah. So is that better? Can you hear me?
Yep.
Yeah. So Medopad, everyone, is online. Well, it's an app that the patient can enter data into. So it's an app that can be used with the hot sites across North West London to monitor those patients that have risks of deterioration. So really those that have saturations of 94, 95%, or those that you have concerns with. So what it is it's an app that the patient can be onboarded to and instructed on how to add their oximetry readings. So they'll be provided with an oximeter. There's lots of oximeters coming down from NHSX at some point as part of this project. So, and they'll be given to each of the hot sites within Northwest London to use. What happens is they add their oximetry, their pulse, and their temperature daily, and there's also questions on resting and exertional saturations, and a dashboard of risk comes out daily to the hot site with order of who they should call. We think it's a very good idea. It's actually worked extremely well when utilised in a similar way in Watford as a secondary care, watching their patients going home with about a similar level of disease severity. So it's starting in Hillingdon. Kildare is doing that in Hillingdon and also in Central with AFI. So they've started using it, but it's going to roll out quite fast, Mahini, I believe. I think within
a week. I know we are expecting to get 20,000 or 15,000 oximetry, which have been coming to Germany, I'm told. So
what it will mean is that these patients will get referred in by the other GP practice within the patch to get watched by the hot site when they are on the app. Now, again, what I've said to everyone is how each borough does this is completely up to you. So really, some people have said we want it managed by the hot site. In other places, they said, oh, actually, we don't just have a hub. We run as other GP surgeries as well that link in. So again, it's just a heads up that this will be happening. The second question, I think, was about use and ease, Mahini.
Yeah, and renal functions in people with COVID, because they need renal replacement therapy and so on.
It's a difficult one. Basically, what we're seeing in secondary care is that patients came in and had more AKI, mainly because they were tending to run dry. So, the initial thinking was, this is like ARDS, we need to run these patients on the dry side. And that wasn't necessarily right. So many patients actually were kept dry rather than euvolemic. And I think AKI occurred as a consequence. I think it also occurs in people that have very severe disease. I would think in primary care, do you need to do regular use and ease? There's no evidence of that actually as yet, Mahini, but again, we're learning on the go. So no. Coming out of hospital, I think if we felt that the renal function needed to be checked, we should be putting that on a discharge summary too.
Lovely, thank you. Vijay, you had a question?
Yes, just Vince, just picking up on what you said earlier on. I was just thinking about what you said regarding the comfortable hypoxia or the silent hypoxia. That's become a real dilemma in my own mind in terms of how we remotely assess these patients, particularly because often patients, when you do remotely assess them, either with video or through the phone, they always tend to say that they've got some degree of breathlessness. Most of the patients I've spoken to have said that they've got some degree of that.
Yes.
And now the fact that you're referring to this comfortable hypoxia makes me concerned in terms of without having pulse oximetry there and then during my triage and assessment. I feel we're going to be struggling somewhat now going forward, particularly those clinicians working in the hot hub, but also in our own practices when we are assessing COVID symptoms over the phone or on video. So I'm now starting to get rather anxious and concerned. It's fine in a hot hub if they've got transport or at the surgery, they can be driven to the practice or the hot hub for us to do their pulse oximetry. But if they're housebound patients, the logistics of going around and doing these pulse oximeters in these patients is going to be a real challenge now.
It is. I mean, we accept that, and it is going to be a bit difficult. But generally speaking, if they are housebound, if they are generally otherwise well, then I don't think you need to worry too much. It's the people that are unwell that have increasing breathlessness. They're the ones that perhaps pulse oximetry is going to be more useful for. So what we're saying is that they may appear to not be breathless at rest, But the ones that, as soon as they start moving, become breathless, they're the ones that have the silent hypoxia. So when we say silent, it's not completely silent.
Right.
It's silent at rest, but it may be silent. It's not going to be obvious when they're sitting there, when you're looking at them. But if you actually measure their respiratory rate, you may find that they are actually breathing at 20 to 30, 20 to 25 breaths per minute. And as soon as they start getting up and doing something, then they become breathless. So when we mean silent hypoxia, what we're saying is that they don't appear to be breathless because their work of breathing does not necessarily appear to be increased because their COVID doesn't seem to make your lungs stiff. And therefore, you don't have to work that hard. It doesn't appear that you have to work that hard, but you do have to breathe faster in order to maintain your saturations. So if you find patients that are breathless when they're walking about, they're the ones that perhaps you need to focus more on in trying to get pulse oximetry to them.
Thank you. That's very helpful, Vince. Thanks. I think we've answered all the questions that we were there. Sarah, was there anything else you wanted to highlight whilst we are here? And then we'll do another one in a couple of weeks' time or once we get version 4.
Wonderful. No, I'm very happy. I'd like to thank all my other colleagues that have helped on the support line and also for my fantastic registrar, Dr. Kumar, who helped put the slides together. So thank you.
And thank you so much, Vince and Sarah, for coming. I think it's really helpful. We've got colleagues from other CCGs. I just saw David Lloyd on there on the chat. So thank you so much. And probably we'll try and do another one in maybe two weeks' time once we get version 4 up and work through what the changes are. So thank you very much. Thanks a lot.